Today we speak with Tash Duffin, who's based here in Perth but works with clients all over the world. Tash is an occupational therapist trained in Orofacial Myofunctional Therapy, pediatric feeding, infant and early childhood sleep quality, and infant reflux. Obviously, this is not a homeopathic episode, although alongside all the many wonderful tips Tash will be giving in this episode, I do manage to slip a few useful remedies in too. The reason I asked Tash to come on the show is that I see so many little ones suffering from colic, reflux, sleeping issues, breathing issues, speech issues, ADHD, and so much more, which can be prevented or corrected with a correct orofacial myofunctional therapy. For the homeopaths and other therapists listening, my hope is that your ears will perk up in this episode and you'll start to see some more options for healing for your clients. For the parents listening, I hope this episode will give you some answers if you've been struggling to figure out what's going on with your child's health. Check out www.wholechildco.com.au, where you can also download some of the incredibly useful free resources which Tash has put together. Enjoy the episode.
Welcome to the Homeopathy Hangout, where we discuss all things homeopathy from around the world. And now my mum and your host, Eugenie Kruger.
Hello, homies, and a very warm welcome to Homeopathy Hangout. Today, we have a guest who's not a homeopath, but is going to be talking about a topic that is incredibly important. And it's something that I see in my clinic literally every single day. And I begged her to come on the show because it's something that I think if more of us can learn to identify this in our clinic from a very early age, we can save a lot of issues for our clients later on. So I have got the lovely Tash Duffin on the show, who is an orofacial myofunctional therapist, amongst a bunch of other things. So say hi, Tash.
Hello, you got it right. Yeah. Hello, everybody. Lovely to be here. So we can call it OFM for short if we like.
Okay, so not OMG, OFM. Okay.
Yeah.
Let's do that. That sounds great because it's certainly a mouthful, which is actually quite a pun in itself.
Yeah.
Do you want to tell us what on earth is orofacial myofunctional therapy, or OFM?
It is. Yes, absolutely. Because it's a mouthful. And if you've never come across it, it's a bit like, what is that? So it is optimizing oral function and breathing, basically. So it's how we use our tongue, our mouth, how we breathe. And particularly in early childhood, we look at why, well, it goes across the lifespan, but I focus on early childhood, babies in early childhood. We focus on how we breathe and how we use our orofacial muscles, because how we use those things affects how it grows. So we want to optimize craniofacial development because that optimizes our airway development, and breath is life, basically. It comes down to that.
Absolutely. Yeah. And I definitely highly recommend that all of our listeners hop back to episode 151 on this podcast with Dr. Shireen Lim, who's also here in Perth, who wrote the book Breathe, Sleep, Thrive, and Tash works closely with as well, because we kind of touch on that there as well. But we're going to go into things even a bit more deeper today. So what got you into this?
My kids, basically. So I'm an occupational therapist by trade. That's kind of like my base qualification. And then I also work with families for doing sleep for early childhood, so babies and early childhood. And my big focus is on sleep quality. So, but when I learnt about sleep, I did a regular sleep course, and then I was thinking, this really, something is off here. Reading, addicted to learning, lifelong learner thing, just like, bits of information, more, and discovered the world of orofacial myofunctional therapy alongside my subsequent children and them having these challenges, and me going, everyone's saying they're fine and there's nothing, and they were healthy, they weren't unwell, but I knew something was off. And, like big giant rashes down face, vomiting, like all the time, slept well, but big open mouth, tongue out. And she was my third, who was the kind of my most impacted by these things. She was the happiest baby of my three. And so nobody cared about the problems I was having because she's happy, she's putting on weight. She wasn't putting on that much weight, but she was putting on weight. So I happened to stumble across some practitioners in Perth eventually. And then I thought, oh my goodness, I love this. I have to do this. I incorporated it into my sleep practice. And then I went and learned the OFM myself. And now I do that alongside my sleep. And gosh, I reckon 80-90% of my sleep clients have oral function concerns. So there is this big melding of when we have airway issues, we have sleep issues. So, yeah. Long-winded answer.
No, that's absolutely perfect. Actually, the reason I came upon you is because quite a few of my clients have said that they've used you and had such great results. And that's why I reached out to you in the first place, because your name kept on popping up. Now, this is the thing, like homeopathy is one of the most incredible healing therapies on the planet. There's really not many things that we can't treat with homeopathy. But sometimes if there is a functional reason for why the person is having that issue, then it's what we call a maintaining cause. So if they're sleeping with their mouth open due to enlarged tonsils, we can usually use the homeopathic to get the tonsils down, and then that helps. But if it's something structural, like a really narrow palate because of incorrect tongue posture, the homeopathic remedies are not going to restructure your palate. So we need to work hand in hand with other professionals, and we need to, as practitioners, be aware of what it is that could be stopping our client from getting the results that they deserve. And this is where people like you really, earn your money's worth, because if we diagnose this early enough, the cranial bones are still so malleable that there's still a lot that we can do. And I put my hand up. I wish I had more of these warning signs with my kids, because they were both fully breastfed until 2. They've never had pacifiers. They've never been thumb suckers. I did baby-led weaning, and still both of their palates are quite narrow. And I don't think I paid enough attention to the tongue posture from a young age. But, there's still things that we can do. And that's why I'm so passionate when I see these young kiddies. I always say to the mums, there's so much we can do. Go chat with Tash quickly, because there's lots that we can do. So maybe, there's so much I want to talk to you about. Let's start with, what are some warning signs that you would look out for to indicate that there is some OFM dysfunction? So what are some of the warning signs? Because there's lots. It can be confused with lots of other things as well. So what are some of the ones?
Yeah. And when I do an assessment, I'm looking at so many different things. When I look at a face, and then I look at the function in feeding, but the giant red flag is an open mouth rest posture. So, because that indicates mouth breathing, and we will almost always, I would say always, see a low tongue posture with that as well. So we have that kind of, that look, and it might not be like that. It might be like that, or splintered like that, but that open mouth rest posture. And from the get-go, humans are obligate nose breathers. So mouth breathing is always an adaptation. A very, very newborn might have their mouth open and they have no issues. It's just because they're newborn, they just need to learn where the tongue goes and build up their strength. So a very, very newborn, if you notice, this is the number one tip. If you notice their mouth open, do the simple push the tongue up to the palate and seal the lips. Don't hold it there, because if there is congestion or whatever and they need to breathe through their mouth, then you want to let them do that. But just start that pattern. Even when you see them, like you see babies in carriers or whatever, and they're like,
mouth
close
open.
the mouth.
Okay.
And we're just starting that pattern. So number one is open mouth rest posture, low tongue, mouth breathing. And that includes when they're awake and when they're asleep. I guess another big one, particularly in early childhood, and this can get a bit muddy, I suppose, but if you feel like your kid is always sick, or they get a cold, the sibling or the peer that also gets that cold's done with it in 3 to 5 days, your kid is like rattly and sounds like I talk about like the Darth Vader babies that you can hear them coming around the corner before they come. But if you can hear your child breathing, or you think they're literally always sick, then that's indicating congestion. They probably then also have that open mouth rest posture. They're probably really struggling to breathe through their nose. And mouth breathers do actually predispose to catching viruses and stuff a little bit more, because the nose is the filter. So when we nose breathe, we warm air, we filter air, And we release nitric oxide, which is important for optimal gas exchange and sleep. But just if we're talking about prevalence of getting sick, when we warm and filter the air, we're literally, if there's allergens or viruses in the air when we nose breathe, our nose will filter out more of those than if we're mouth breathing. We don't filter those out. And the air's not prepped for the lungs. So anyone that's got one baby that mouth breathes, I had one, two, and I know particularly my third, when she got sick, she was sick. Like because she have a virus, and then on top of that, the air is not being warmed and humidified and for the lungs. So the lungs can almost like it spasms a little bit. So when you're sick, you're sick. So yeah, they're probably my two huge red flags that you can hear and see. And really, what's the saying? You should breathe with your mouth as often as you eat with your nose. Unless you're sick. If you've got a cold, it's okay. But otherwise, we don't.
Okay, that's so good. And not even to talk about the dental health side of things, of sleeping with your mouth open, the saliva drying out, and then the anaerobic bacteria being able to play havoc with your teeth. So that's, another great reason to make sure.
If you're not sure, if your kid wakes up with bad breath, they're mouth breathing. The bacterial growth. Yeah.
Absolutely. And talk to me about tongue ties, because that's some people are like, oh, it's just a fad, it's just the new thing. Some people say it's all the folic acid that's in the supplements, and people that have the MTHFR gene mutation can't convert that into folinic acid, and there's all these things. So are there actually that many tongue and lip ties, and how do they affect OFM?
So I guess in my practice, my sample is skewed because I see a lot of them. And I wouldn't say they're a fad. I would say there's more professionals, thankfully, that are aware of them. There's still not enough. There's still way too many families that, including myself, but with my children, that go through multiple GPs, peds, lactation consultants, midwives, child health nurses, until they get to someone that goes, have we seen what's going on in the mouth here? And one of the most tricky things, I think, is that it's not a quick look under the tongue. So at every birth, I'm sure, well, mine, the pediatrician looked under the tongue, no tongue tie. But that's not telling us anything, because diagnosis is not based on appearance, and that is the big why it's so wishy-washy. If we could say, if the ones that are really obvious that cause that kind of heart-shaped tip like that at the end, they generally get picked up in a little snip, which is normally not enough, but it's better than nothing. So those ones get picked up because, look, we can see that. Yes, I can identify that. Diagnosis is based on function. So a look under the tongue tells us nothing except the appearance. What we want to do is feeding should be assessed, and we want to feel the tongue. We want to feel under the tongue. We want to feel how it moves sideways. We want to feel how it cups. We want to feel how it extends. That's another thing that often it's like, they can both poke their tongue out. So they might be able to go. And then no, that's not tongue tie, but that's one movement. So if you think about all the things your tongue does, if we're just doing that, you can't breastfeed the tongue does that. It doesn't lift. The tongue has to lift, cup, peristalsis. We want it to lateralize, all these things. And I think that's why it's so hard to diagnose, because unless you seek out extra training, no speechies, no OT, no dental practitioners, no registered dental hygienists, none of us learn it at uni, none. And, like a lot of those professionals are literally focused on the mouth, and we don't learn it at school yet, hopefully.
Yeah, I hear you.
And there's that whole then bias of like, well, if I didn't learn it at school, I'm not interested in it.
Yeah, no, I hear you loud and clear there. It's interesting. I'm just thinking of my own son, who I never had any breastfeeding issues. He put on weight absolutely great. But looking back now, like I get him to stick his tongue out to take his remedies, and I can't even stick his tongue out. And there's a little bit of a lisp, which I have as well, but I've got all those, I was that kid that was like, with the tongue hanging out the whole time. And my mum was always saying, oh, you're catching flies, you're catching flies. But there wasn't, 40 years ago, any of this sort of advice. But then also one dentist said he had a tongue tie, another one said he didn't have a tongue tie. And, there's, it's so hard to know sometimes. And then also, just doing a release is just not as easy as that. I had one dentist describe it like, I think it was Shireen that said in the podcast episode, it's like releasing a tiger, in a cage if you just suddenly snip this tongue without the proper training and stuff that goes with it beforehand. But this obviously also depends on the age, because if you have a newborn baby, you pick it up, then you do the snip. My clients have said that usually it's just a day or two of the baby trying to relearn how to use their tongue. But for others, it actually takes a little bit longer. So that can be a tricky one. What else can you tell us about tongue ties? Because I know there's going to be so many mums around the world listening whose ears are going to perk up right now. So just as much information you can give us about tongue ties.
So that it's normal to be missed a lot. And if your gut is telling you that you think that might be it, even if people who are really smart at other things have said they don't think it is, keep going. It is very much not just a snip, like you mentioned. There's no other surgery that we do in the body. I worked in physical rehab in hands for many years. No orthopedic or plastic surgeon does a surgery and then goes, bye. Well, no good one does because they don't get good outcomes. And it's the same. Scar tissue is scar tissue. We have to, the role of pre and post rehab is to prevent adhesion and to promote the movement, because just because you create range of motion of the tongue, so if that's a floor of mouth, that's a tongue, and we used to go here, we can physically go here now, we don't know how to do that unless we're trained. Some kids will pick it up, but some are just like, they don't have that motor planning capacity to understand, oh, here we go. And the tongue forms in utero really early on. So dysfunctional sucking patterns cemented from that about 15 weeks when we start sucking, and then we're getting all the way, we're practicing swallowing that amniotic fluid a lot in the last trimester. Then even if we have a tongue tie release at 2 weeks old, we're not actually 2 weeks old in terms of our dysfunctional patterns, where I can't do the maths, but gestation plus the 2 weeks. So those dysfunctional sucking patterns and the dysfunctional rest posture doesn't just magically appear a lot of the time. And because if your tongue is restricted and it's resting low in the mouth, in utero, the palate that's how we're often born with, not the only reason, but have babies that are born with high narrow palates, because the tongue rests, the tongue is suctioned to the palate and helping shape a broad, shallow palate in utero. That's going to obviously pay us dividends when we're out in the real world. And if the tongue is resting low in utero, and obviously when you're born, but if the tongue is resting low, the tongue, there's no inner force inside the mouth pushing and shaping out. The cheeks and the lips are an unopposed force, and they push in, and that's where we end up more likely to end up with those higher, narrower palates. And then we get into that problem of, depending on how narrow it is, but if you have a super narrow palate and you release the tongue and the house is too small and the tongue can't get up there, then that's a whole other bag of complication. So getting the tongue up as early as we can, obviously, because like you mentioned at the start, newborn and little kids are so moldable. And that's what drives me crazy about the wait and see, because why don't we want our kids to be breathing and sleeping as best as they can? And I'm not just talking about the naps and sleeping through the night and all that kind of crap. I'm talking about the quality of the sleep, the capacity to have good breathing, so nasal breathing during sleep, that lets our nervous system get into rest, digest, restore, lets us get into deep sleep. When we mouth breathe during sleep, we can't get into that rest, digest, restore. We are in fight, flight, which impacts our sleep quality. So even was my daughter. She slept well, in inverted commas. She was a 12, 13-hour a night kid. I had to wake her up in the morning, but that's because that was her body's way of going, I am exhausted. I'm in bed, but I'm not getting this deep restorative sleep. I'm up here in this like sleeping with one eye open to make sure there's no tigers coming, because my nervous system is like, something's not right here. My oxygenation is suboptimal. So that's what drives me mad about the old wait and see, because we can make these little changes early on that just snowball in a favorable way. And the inverse can be true if we don't identify or aren't aware of or are ignored, and things cement and they snowball. That's my core belief, that I just we want to get in early.
I feel exactly the same. Like I said, that's why I have you on here. I was listening to another podcast the other day. It was so interesting. And they were talking about, when you don't have this correct tongue posture, when you sleep, you're basically in paralysis. The tongue then slips back in case of sleep apnea, slips back drop into the airway. And then you have this spike of cortisol, which, like wakes you up, and then you're like all wired. And I was like, wow, that's so interesting. It just makes so much sense. So your body's never, like you said, getting into that relaxation state. And I was reading something else the other day that said with nose breathing is how you activate the vagus nerve. And so you're seeing all these ADHD kids, behavioral issues, kids waking up really grumpy. And it's because they're not having restorative sleep. And that's 100%. Like, once again, if we can just, all these mamas with little babies, if we can just get you to really get onto this. And I just want to say this as well, with osteos and chiros, I think they work beautifully alongside all of this work that you're saying. So if you're having a tongue tie release done, go to your osteo or your chiropractor straight away, so they can just, release that tension. And just, if there's been a traumatic birth or forceps or anything like that as well, they can also shift the cranial bones. So go to your osteo, go to your chiro, go and get these things checked out. I had a baby in the clinic, a little 1-year-old in the clinic this week, and it was crawling with, one leg to the side and one leg under it. And they had forceps at birth. I said to her, he's still only one. Go take him to a chiro, because I'd never been to a chiro, never been to an osteo after this, the forceps. And I use arnica, or, depending on, we've got different homeopathic remedies that we use for this type of birth. And we can use that in homeopathic potency, but then also go and see your chiro, go see your osteo, get onto these things before they become an issue. And I said to her, it might be nothing. You might only need 1 or 2 appointments, and then you sort it after that, but just get onto it nice and early so it doesn't become an issue later on.
Yeah.
I had other, yes, go.
Oh, they're good professionals to have in the release team. And I will just comment on that and how you mentioned with the cortisol and the startling awake. And I see this all the time in my sleep practice, where families will say either that, like, that the kid always startles awake. They never like, and call out. They're like, bah! From like fast asleep to like, come and get me. Or kids that they're just like, I've fed them and I'm lying with them, I'm doing everything, and I feel like they want to go back to sleep, but they can't. And I say, do you know what? You're right. It's like, if you hear a really loud door slam, and you can feel that hormonal, like, fight, flight, let's go. Oh, it's just the door. But you can feel that. And that's what's happening. They're startling awake. Their hormones are saying, run from that tiger. They're like, oh, there's my mum. Okay. Oh, I still can't calm down, and I can't get to sleep. And then the comment about ADHD, yep, 100%. Depending on where you look, like, even they say somewhere between 20 and 40% of kids with ADHD have have some sleep concerns. And a lot of the kids that when you treat their sleep disorder breathing, then a lot of the symptoms disappear. And those that do have the ongoing ADHD diagnosis need less medication. So they're literally exhausted because they're operating on such poor quality sleep. So I would love for ADHD screening to, even before before it's raised with a parent, to be like, how's your kid sleeping? Are they snoring? Are they mouth breathing? That should be our number one question.
Yeah, absolutely. And I listened to another podcast the other day. I sometimes feel like all my conversations start with I listen because I do so much driving because we live rural. So I listen to podcasts all the time, but they were saying 80%, they reckon 80% of ADHD is actually poor quality sleep. And I would not question that at all. I would definitely agree with that. I just want to
100%,
say
mate.
for the
Yeah.
homeopaths listening, homeopathic cortisol and a 6C potency, I have that in a bottle of drops, like homeopathic drops next to the bed. So if your child does wake with that startle reflex and you feel it could be the high cortisol, you can give them homeopathic cortisol drops in a 6C potency to just get that cortisol down really quickly. It's one of my favorite remedies. I have so many clients who are constantly on fight and flight, us mums, all these, just busy. And sometimes I'll just get them to put the homeopathic cortisol 6C drops in their water bottles, shake it and just drink it throughout the day. And that's been one of my cool little tricks. Is there anything you want to add to that? Because next I want to go into like another really big one is colic and like how this, if you've got the tongue tie and you're breastfeeding and the colic and reflux and how that all plays in as well. So I'll just leave you with that big one there.
The colics and reflux are not diagnoses. They are symptoms. They are terms very often thrown at women like, your baby's grown. I don't know what's going on. They'll grow out of it. Because one day they won't be a baby anymore, so they will grow out of it. Probably. But hey, why don't we try and help them in the meantime? So reflux is literally, I always get is it a verb or an adjective? I'm not good at that. I'm not good at my English. It's describing the backward passage of food up the esophagus. It's not a diagnosis. So in most cases in infancy, reflux is not your GERD or your GORD, your gastroesophageal reflux disease. More often than not, it's what we call AIR, air-induced reflux. So literally from swallowed air. So with a tongue tie, we have dysfunctional patterns of movement of the tongue. There can be like gaps, a really loose latch, popping on and off, lots of crying, because they're frustrated or tired, but I'm hungry and I want to eat, but I don't know how to get it out, blah, 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 and all this, and they swallow air. So if you think about the stomach really simply like balloon, if you fill that balloon with just milk, the stomach walls distend, then the receptors in the stomach walls go, yep, happy days, full, we can finish now. And then starts to churn and makes the chime and stomach acid in there, and then that'll go in through the rest of the digestive system. If we fill that balloon with not half, but half air, half milk, stomach will distend. It doesn't know what's like. It's not like, oh, there's some air, and it's just like, okay, we're done, full, because the receptors have stretched. Then we start to churn. That air has to go somewhere. We've got stomach acid in there. So as that air comes up, we get the reflux episode. If the air goes through, and gosh, I've seen some photos of these babies that you like, literally, it's like a cartoon, like their stomach is about to explode if the air ends up through the other way. But that's what's happening. So I probably don't need to say this to this audience, but I implore everybody, before you go on reflux medication, get a feeding assessment by someone who's trained in oral ties, because there's so much research out there now on how mostly it's AIR, and there's a lot of good research on improvement of symptoms, or resolution of symptoms, I should say, post tongue tie release. So the medication, all that's doing is changing the acid. It's not addressing the root cause of the reflux.
And is AIR also silent reflux? I've heard the term silent reflux thrown around a few times, and I'm not really sure what that's about.
Just means that it's not coming out. Okay. So we've got coming up and then going back down. So and that might be because there's not enough air to do that. And so if you think about those projectile vomits that just go across the room, they're like chunks of like big amount of air. The silent reflux is coming up and going back down. And I guess the other point on that is that not all refluxy baby, I mean, if you've got a really upset refluxy baby, you know about it. My baby was refluxy as hell, but happy. But it's still, so she wasn't bothered by it for whatever reason, but it still caused inflammation in her nasopharynx space still caused her adenoids to be blocking 80% of her airway by the time she was 8 or 10 months. So she wasn't bothered, but it was dysfunctional feeding and it was causing other systemic things happening. So, yeah.
Yeah. And, then we have terms like, oh, she's a happy spewer. And somehow, they kind of, we think that kind of makes it okay. It's like, no, she shouldn't be spewing. We need to investigate this further. But I also want to say this is where I feel we're almost shooting ourselves in the foot with homeopathy, because homeopathy is so good with treating colic and reflux. So those symptoms go away, and then we don't think to actually go and investigate further about what the oromyofunctional is like, what is going on there. Because with, like you was explaining about the gas in the stomach, we've got such good homeopathic remedies that help with that. And it's safe and effective and it's beautiful. Those symptoms go away. Our nat phos tissue salts, which is called the acid neutralizer. I've never not been able to help a baby with colic and reflux with our incredible homeopathic remedies. So then the symptom goes away, and then you don't think to go and actually investigate further, which is also why I just want, especially the homeopaths, to really it's great that you're helping this baby with their symptoms of colic and reflux so everybody can, sleep and happy times, but just also be aware of OFM. Just get the mum to go and check and say, okay, great, we've, helped you with your symptoms, but there could be something deeper underlying going on. Just go and get it checked out, because you're just going to save yourself a lot of heartache later on if we get onto it nice and quick.
Yep. 100%. Yeah. And I think symptom management is super important. And, sometimes even like your omeprazoles and your PPIs, sometimes like babies is in just so much pain that it's a good short-term thing. But
it's not. Homeopathics is much better. Just please never give your child that unless you've tried homeopathics first. That I can say it. Yes. No, absolutely. No. We have and do you know what? The homeopathics work faster than omeprazole and things like that without any of the side effects. So I just there's just never a reason, in my opinion. And I just have to say, I'm not anti drugs at all. Like, there's definitely has its place. I just feel with babies, there's so much that we can do with homeopathy without the need of drugs, and especially because there's so little. A lot of these things are not tested. These medications are not tested on babies. You don't know what the long-term side effects are. So if we have a safer alternative, then let's use it and leave the drugs as a last resort. But anybody who listens to this show will know I'm not against medications at all. They definitely have their place for sure. Can you talk to us about dummies or pacifiers, and also about myomunchies and whether that was a good alternative? So yeah, talk to us about that, because I see so many of these kiddies with their thumbs in their mouth all the time, and they're dummies, and it's just so it's so hard, because it's also socially not acceptable to go up to a mum and say, hey, I think you might have to rethink the dummy, because it could be affecting your child's oral development, because then you get slammed down. You definitely don't ever want to say that on social media. But even though it's coming from a place of actually just wanting to help the child, it's such a socially acceptable thing that you almost have to be really careful what you say. That's certainly how I felt.
So dummies, bar one or two designs, all reinforce a low tongue rest posture. So even the orthodontic ones, which are an oxymoron, they're no good. They all make the tongue sit low in the mouth. So the goal of orofacial myofunctional therapy, or optimal oral function, is tongue to palate. So lip seal, nose breathing. So if we've got a dummy in our mouth, we certainly not doing two of those. We don't have our lips together. We don't have our tongue down. And yes, sucking is obviously very, very calming in infancy, and that's great. But ideally, and, there are protective factors in terms of keeping you in lighter sleep and that kind of things. So if you want to use it early on, that's fine. But from an oral function perspective, I always recommend that you try and stop by 6 months. If you're over that point, or you're like, I don't know about that, then it's only for sleep from 6 to 12 months. And I would also practice it. You can have a suck to go to sleep, but then I pull it out so that it's, because it's all about duration, frequency, and intensity. So if you're having a little 5-10 minute suck before you go to bed, and then the tongue goes to palate, lip seal, nose breathe the rest of the night. Big deal. But if you're sticking there, and then what invariably happens is it falls out, and then we've got the whole game. We've got mouth open, low tongue, mouth breathing. So these little guys, the ones that, these are an American company actually. So these are, they're called a Nini pacifier, these ones here. So they look weird, right? So they have a wide base, which replicates more of a breastfeeding like latch. And to keep it in your mouth, for the child to keep it in their mouth, their tongue has to do peristalsis, which is what we want for breastfeeding. Other dummies go, so we're building up all these muscles that are going to create
in the cheeks,
reinforce this and higher palate. This, like we use this as a therapeutic tool to strengthen suck. And because it, they can strengthen the suck without the kind of the added pressure to swallow as well. Like they can just work on coordinating that suck. But these are really good. And because there's only one size, they kind of age out a bit naturally as well.
Oh.
So they're really, really good. And that they are American, and I stock them, but there's only a handful of people that can get them in Australia. The only other type, which is similar, is the event. Doesn't have that wide base, but it's got that cylindrical, so that the tongue will cup it. But by far the Nini is my fave. So yes, they do affect palate development. They affect tongue function. They affect how the teeth come in. You'll often see those real like literally is like a hole in the front of the teeth, the open bite, the overjets. So it's because of literally something being in the way, but then also the deforming forces that are happening. So I guess, if it's got to be for sleep, okay, take it out. But if your child is walking around with a dummy in the mouth all the day, you've just got to start implementing boundaries to reduce it, because we're always thinking about duration, frequency, intensity where we can, until we can then get rid of it. Some suckers are generally airway kids. So they are doing it because they might have reflux. So they're sucking to get the saliva to soothe. Their tongue isn't suction to palate because they're mouth breathing. So they've found another way to stimulate their nerve endings for endorphins, or their palate's too narrow to get their tongue up. And so often people worry about, I want to give a dummy because I don't want them to become a thumb sucker. But if there's no dysfunction, it's very unlikely that your child's going to become a thumb sucker. It's generally a flag for something else going on. And so the munchie is great. So it's an Australian company.
Oh, I didn't know that.
Yeah. So this is a very old one, not that you can see the detail. But so what it does, a lot of things. So it gets your jaws lined, it gets your lips together, it's working on chewing, which with processed food, et cetera, we don't necessarily do enough of as these days. And we nose breathe when it's in. So if your babe just has, lots of babies love sticking things in their mouth, you can absolutely go for something like this. Some babies just don't like can maybe feel a bit full in their mouth. There's all different sizes and things, but like even there's lots of kind of, and not like this is for a bigger kid, but something that's long, a little baby one would only be about that, where we're working on chewing for that oral stimulation rather than sucking past that real infancy stage. Because essentially sucking is very calming and it's a source of regulation early on. What we want is for, obviously it's co-regulation, but for regulation to transition from sucking to pro-social engagement, which means co-regulation. So we want to move away from that sucking to be not only in terms of regulation, but in terms of orofacial development as well. Craniofacial development.
Yeah, and affecting speech later on as well, which is a whole other topic too. But I just want to say, from a mental, emotional level, like whenever I see things, I'm always thinking, what what is this going to lead to? You know, if you continue with this behavior, what will it lead to? Where does it come from? What triggered this behavior? And in the homeopathic consultation process, this is where we will kind of look at homeopathic remedies that maybe take the mum's case during pregnancy. Maybe there was a fright or a shock and the baby didn't feel safe. So we'll give a homeopathic remedy for what the baby would have felt while they were in utero. But we have homeopathic remedies like lac maternum, which is made from the breast milk of 9 different women. And sometimes we can use that to help a child to stop thumb sucking and dummy sucking. I often use the remedy Ignatia, which is a remedy for grief, loss, and disappointment. So as they're taking the dummy away from the child, you can give them these homeopathic remedies to help with this process. Another one is the homeopathic remedies made from oxytocin, dopamine. We have all these neurotransmitters that we have homeopathic remedies made from. Sometimes I use remedies made from butterflies because it can be that transition from, transitioning from a baby to a big kid where you don't need the dummy anymore. We can use those remedies as well. So we can support it on, all sorts of different ways, which is really nice. But the other thing that I just worry about is if your child is sucking on this thing the whole time, it feels to me that it's starting to lay those addiction pathways where they're feeling they need something to make things okay for them. And, the child hurts themselves, the mum sticks the dummy in, or the child's a little bit frightened, they stick the dummy in. So it's giving them, it's laying those pathways, those neural pathways of something is wrong, I need to put something in my mouth. Or, I need to suck on something, and then, I just think of eating disorders and all sorts of, all of these addictive things that our kids are doing, like technology, and they're all starting to lay those addiction pathways. So then when the child's 18 and they have access, much younger these days, but 18, they get access to drugs and alcohol and things like that. I feel those neural pathways are already laid like highways, and it's going to be much easier to kind of just go along those highways. So I really worry about it from an addiction point of view when you have these babies that just, you just cannot get the dummies out of them. And then also having plastic or rubber or silicone or whatever it's made from in your mouth the whole time. I mean, it might be BPA free and all those sorts of things, but 5-10 years down the track, we discovered that these materials are not actually safe for us, and they endocrine disruptors and this and that and the next things. So yeah, I think there has to be safer ways. I mean, in South Africa where I'm from, we just all get given biltong, or beef jerky it's called over here, to chew on.
Oh, really?
But yeah,
that's great.
It was actually
so
my
good.
son.
Your development's amazing.
Oh my gosh. We were like, when my son was 3 months old, we went to South Africa, and I didn't even see it, but my stepdad just gave him like a piece of, we call trove, which is actually, it's like dried sausages. And so my son was just like sitting there at 3 months old, like chewing on this dry sausage.
Better than a wrap.
Exactly. Well, we get given rusks as well. That's a very South African thing. But talk to us about baby-led weaning and pureed foods versus like just kind of bringing it home, this thing of chewing and developing these muscles, and how important that is, because
and I think I touched on that ever so briefly just before with my comment about processed food, and it's an epigenetic changes that we see in skulls and palates and teeth, like over since the Industrial Revolution, basically, where we've cooked food, so we're no longer doing this on raw meat. We've got all these processed things. And even if you're not like necessarily eating out of a packet much, we cook our carrots, that kind of stuff. So there's less opportunity. And that's why we've seen these epigenetic changes of narrowing faces. If you look at tribes that don't eat any of our processed food, and they've got these smart, like you look at their teeth, they are all amazing. They've all got beautiful, broad smiles. So, and with babies, obviously I do believe there's a place for puree and there's a place for whole food or baby-led weaning. I like, because I'm always also thinking of sleep as well and nutrition and how there's specific nutrients that are important for sleep. We do want to be supporting that and making sure our baby's getting some food. So I always advocate both. Do a mix of both, because we know puree-fed babies tend to initially get a little bit more in, so they can get some more nutrients. But baby-led weaning babies get better oral motor skills. So why not do both? So you put a piece of avocado or some steamed zucchini for them to pick up, and you might have some pureed meat and sweet potato, and you're doing that and that. So we're getting the best of both worlds. So that, like with the biltong or just this, because this is here, but that movement or practicing on a chop or things like that that kind of movement. Even if they're sucking on a chop and just having a go at it, they're probably not going to eat it to start with. But that is all amazing for jaw development and helping broaden and reducing that open mouth rest posture, all that kind of stuff.
And you can make your own beef jerky really easily in your dehydrator at home as well, which is great. Just stick it in there. Yeah. Can you talk to me about mouth taping in children? It's something that I've wondered about myself. I've been mouth taping for about 8 years because, like I said, I'm doing some palate expansion that I've done for the last year. It's helped a little bit, but I'm a bit lazy with wearing my palate expander, and physically my lip is too short. So actually for me to close my mouth is really, really hard. So I started taping my mouth 8 years ago, and it's made such a big difference. But when can you start doing it in children? And is it something that you would recommend, or what's
as a parent, never do it until you've seen a professional that has given the all clear that the airway is clear, because literally you could be suffocating your child. If they are mouth breathing because they have nasal obstruction, you're blocking off their lifeline.
Okay.
Do not do it. And even as an adult, I mean, you're an adult and you can take it off if you're like, oh, I feel a bit hungry for air, I can take it off. But I would want to be assessed by ENT or orofacial myofunctional therapist to know that the airway was clear. And because also remember that a clear airway now in the day, I have a dust mite allergy. If I had that untreated, my airway might not be so clear at 2 a.m. in the morning. So I'm an adult, I could easily wake up and take my thing off. But if we've got and I know there are different types of tapes that kind of just go like that. So you can technically breathe around them. Or there is, I'm talking about for sleep as well, obviously. Taping for sleep. There's this tape that kind of goes around like a box.
I've seen that.
That's a really good one for creating the habit. So it's like that kinesio tape. So what it does is it's got the floors that pull in. So you could talk with it on, but then every time you relax, it goes, like that. So that is, if the airway is patent, I would definitely start with day. So you've got the all clear, airways patent. That box tape's a nice one for the day, because also what kid's going to sit there with? Not talk, none of mine, for an hour or so during the day, but a good kind of retrainer to help it come back in, to teach it a new rest position.
Amazing. I know you specialize in children, but for adults that are listening to this and realizing that this could be the root of some of their issues, like where would adults even go to get information on this, or is there much that you can still do as an adult?
It's much harder, as you've touched on with your palate expansion, like so my son, we actively expanded his palate for, I think it was 8 to 10 weeks. And like he went from no gaps to like he's got giant gaps in his teeth, like just because everything's moving. So it's like literally like magic before your eyes. Whereas because our bones are set, it takes a lot more to move them. So yes, there's just definitely things you can do. And because it's not always palate, it might be something to do with your septum. It might be, from my dust mite allergy, I had something called alar rim collapse, where I would breathe in and my nose would do this instead of go out. So I had surgery to correct that. So now I can breathe through my nose.
We also have a homeopathic remedy for that, right? We've got a homeopathic remedy made from dust mites and house dust. And I often give that to clients as well. And I have 2 drops before sleep at night. It makes a huge difference. So I'll send you some notes.
Yeah. I'm like writing all these notes. Yeah. So there is definitely things. So you can see an adult ENT. You can, and because a lot of things and obviously everything's really expensive, but if you've got dysfunctional breathing, you can actually get it's covered by Medicare and things like that. So it's like you can get an inverted commas nose job because it's a functional thing. So yeah, see an adult ENT, see an adult orofacial myofunctional therapist, see an airway focused dentist. I guess the hardest thing is finding that first person in your area, because generally there is some connections, thankfully, these days that can then lead on. But I guess finding an adult ENT is probably one of the easiest ways to go. I know they're not necessarily as holistic, but if they'll be like, okay, well, you've got enlarged turbinates or your septum's deviated, and it can at least put you on okay, this is where I need to start looking. And even having just reading, it does not treatment, but just for knowledge, Breath by James Nestor is a really good resource to start you going, oh, okay, I see why this is important.
Amazing. And Shireen Lim's book, Breathe, Sleep, Thrive.
Yeah.
I really like that one. And it's only like $20 or something like that on Amazon. It's really good.
Yeah, that's amazing.
And you have an incredible little free download that people can get on your website as well, which I downloaded it and I copied it into my Facebook group and said to everyone, read this, tagged everyone, because it's so important for them to be, like I said, I really just want us to get onto these babies straight away, because the amount of issues we can prevent later on is really phenomenal. So if people go to wholechildco.com.au, they can download the booklet and they can book a consultation. Now, you can actually do the consults online as well. And on your Instagram, if people go follow you there, you explain how you're able to do that, which is really great. Because I asked you that question last year. I was like, how do you do that? And you directed me to your Insta page, and there's some great info there. So just tell us a little bit, tell our listeners how they can work with you, and if they're overseas, what they can do and how you work.
Yeah. So I do lots of assessment via photos and videos. So like for a sleep client, I will, because nothing ever is really, very rarely is it just sleep. So I'm assessing all the things through photos, videos, feeding, all that type of stuff. A big questionnaire, which gives us lots of history and things like that. So if you're wanting to work, if you're not in Australia and you're wanting to work with me on sleep, then you can book directly, but if the times are all like wacko, please just DM me and I can sort that out. If you're wanting pure OFM, best to work with someone, even if it's online, but best to work with someone just in terms of like registration. I think it's probably better.
Oh, got your registration.
Yeah. So pure OFM to work with someone in the States. But you can always, and I do know a couple of people that do that and can always ask around as well. So, yeah.
Incredible. And all the places where people can get hold of you, your website, I know I've just mentioned it, but just kind of run them, just in case I've missed anything, just run people past all the places of how they can get hold of you.
So Facebook and Instagram are at wholechildco.au and website is www.wholechildco.com.au and hello@wholechildco.com.au.
Super email. And any final messages that you want to leave us with, or anything that we might have missed that you want to make sure that you mention?
I think I covered everything, but just, early intervention. And if your gut, even if people that are really smart at other things, and this is not their specialty, because it can't be everybody's specialty, and you feel like something's wrong, keep going. Because it'll be worth it in the end. These little things we can do early on can literally be life-changing.
Oh, absolutely. So lovely to connect with you, Tash. I'm looking forward to us catching up in person sometime soon. I have had this, I don't know if I've mentioned this to you, but it's something I've been in my head for like 2 years, but I really want to get some of our holistic practitioners around Perth together once a month in person, and then have one guest speaker so we can all learn from each other, get, the chiropractor and all these.
Because even like a couple of things you said, I'm like, oh, that sounds amazing.
Yeah.
Like that homeopathic drop for cortisol. Because like, honestly, like the number of times mums will say that it's just like they really want to go back to sleep, but they can't. I'm like, yeah, they can't, because their hormones are like,
well, that's why I feel like more of us can get together in person and just learn from each other's specialties. And, it's kind of, health is such a big topic, and there can be so many different reasons for why you're struggling with what you're struggling. And the more we can learn from each other, and that's why I love this podcast as well. Like I might have a client that I'm struggling with, and then I interview somebody and then they say something like, oh, that makes so much sense for that person, kind of pops up into your head. And that's why we're so lucky these days with the internet and with all, all these different ways that we connect with each other and can learn from each other. So all that to say that I hope to catch up with you in person soon.
Me too. Lovely to thank you for having me.